thank Dr. Berger, Dr. Joseph for inviting me here. The year in Kings County was definitely memorable. So I graduated Kings County Hospital in 2009 and went out to practice in the real world with no experience in the real world. I ended up going through probably about 12 associateships in less than a year, and it wasn't pleasant. And this is from somebody who loves dentistry, who loved NYU, who loved Kings County, and I would just go from one associateship to another, and I didn't like what I was doing. I didn't like where I was working. The environment wasn't the right environment. The instruments I didn't have that I wanted. And I wasn't doing dentistry that I wanted to do. So after my last associateship, I said, it's time to maybe take a risk and try something. Try something on my own. You know, you're still young. If you fail, you fail. And I wasn't afraid to fail. It's not a big deal. If you fail, just start over. You're still young. So January 2011, I started to practice. Against conventional wisdom, people tell you it's a recession. It's a bad economy. It's not the right time. You got to wait it out. They don't tell you go where there's no other dentist. Why would you go to the city? There's 2,000 dentists. And I just figured, let's try it. What's the worst that could happen? So I started renting a chair first twice a week, right Midtown Manhattan, 36th and Park Avenue. Little, small, tiny office. And started learning, continued being a resident, teaching myself how to run practice. And things went okay. I didn't sign up with any insurance companies. I figured it's never too late to sign up with them. So we went fee for service. And at the beginning, you sit around doing nothing. You see one patient a day, you see two patients a day. And after 3 months, we went to 3 days a week. And we went to 4 days a week. 10 months in, by October 2011, I was ready to expand. And beginning of this year, in January, we moved to a brand new office. The office is open 6, sometimes 7 days a week. We run a full-time practice, a busy office. And it's the practice that I always dreamed of. And I'm thrilled, I'm happy. I'm glad to go to work every day. Even though it could be usually a 12 or 14-hour day, it's great. I love it. I wouldn't trade it for anything. And let's talk about it. So how do you make it happen? And there's 100 ways to do things correctly. There's 100 ways to do it wrong. I'm just going to share my experiences, the philosophy I developed, and I'm still learning and learning every day. And some things will change. Most things will change in the future, but this is what I believe now. So how do you build a recession-proof practice? That's my new office, by the way. So we'll talk about one way is external marketing, which is we're not going to talk about today. This is what anybody could do. It doesn't take much skill. Just you need financing, whether you do a newspaper ad, internet ad, commercial, TV, radio, whatever. This is the focus. This is what separates us from the rest. This is why we could survive with 2,000 dentists in a 1-mile radius, 40 other oral surgeons in my building, periodontists, orthodontists, 3 dental labs, and it doesn't matter. So what is internal marketing? And are you doing it? We're all doing it. Whether you're in Kings County, or your Brooklyn office, or you're in Queens, you're in Ohio, you're in France, you do internal marketing every day. It's everything you do. And patients see everything you do. And that's your marketing. You can't not do it. You can't opt out. You're doing it. So why not just do it well? Why not do better than everyone else? And patients talk. Every patient will tell 20 people about the experience they had in your office, at least. So why not have a free commercial? Why not have them go talk about your practice and say nice things? And with internet now, they'll go online and they'll post reviews, and thousands of people see those for years and years to come. So you can't now do this and survive. So my philosophy is we have to wow every patient. gotta wow every patient. Because not only do we want them to come back, but we want them to tell all their friends, family, and co-workers about what a great practice we have. So let's run through some things that are internal marketing. First of all, there's no wait time in my office. Patients' time is important to us, and they're busy. And if you waste their time, even 5-minute wait, in my office we apologize profusely if that happens. That's not acceptable. The office got to be spotless. They don't know how good of a dentist you are. They don't see what you do to them. If the office is clean, that means you run a clean office. The restroom is the most important room in your whole office. You got to get checked 10 times a day by the office manager. It's got to be spotless. You need good staff. Your staff are your backbone. Without your staff, you have nothing. You have to treat them well, you have to pay them well, you have to train them well, you have to invest the time in having great, professional, loyal staff. And without them, you cannot be successful. These are the most important people. My staff have uniforms because we're a team. And we provide patients experience as a team from the minute they walk in through my doors to the minute they leave, they get an experience. And that's internal marketing. My office doesn't smell like a dental office. We don't want that. We have scented candles in every room and the reception area, and we get complimented constantly about how well our office smells. We offer Netflix and Pandora. This is the cheapest advertising and the best advertising there is. They love it. And this costs virtually nothing. So rather than spending $3,000 a month on a newspaper ad, spend $30 a month on Netflix or $18 a year on Pandora. We have the dental vibe for pain-free injections. Because we all know the bigger they are, the more afraid they are of the dentist. And there's maybe a dozen dentists in New York who have this machine, and it's priceless. I have patients, when this breaks, who will refuse treatment. They tell me, Dr. Mann, I call them, I tell them, listen, John, I know you love our dental vibe, but it broke. They're like, Dr. Mann, that's okay, but I'm going to wait for our next bridge until it gets fixed. And that's fine. And they love it. And we use first a very strong topical with 3 different anesthetics. Then we use the dental vibe, and our injections are pain-free. If you don't hurt your patient, they will come back. And this is marketing. So, for the rest of the lecture, we'll talk about the things in red. It's great to do all this marketing, but you have to be able to actually do dentistry. And the more you do, especially in a poor economy, the more procedures you can offer and do them well, the faster you'll grow, because you'll be able to help more people. So we offer a very wide array of procedures and services. We even do orthodontics, braces, Invisalign, implants, root canals, I mean, you name it. I still refer out and work with great specialists, but we try to keep as much as we can in the office. You got to perform procedures efficiently and less invasively, and we'll talk about this a lot. This is my philosophy. Get them done. People have things to do. They got a babysitter, they have a job, they have a life. They can't spend years in your office. They have to get in, get their treatment done. The faster, the better. We do sedation, which people love. Everybody's afraid of the dentist. You put them to sleep, they don't remember anything, they love you for it. All patients have my cell phone numbers that we do procedures like surgeries on. I get called maybe twice a year at best. We also have a 24/7 answering service, and people rarely bother me on my cell phone, but they appreciate it. And I feel better knowing there's an emergency that I'm the first one they call, and they don't go to the emergency room. And you have to work with a great dental lab, and I'll show you why in a bit. So let's take a look. So we have our first case. So this gentleman presents to us, and now it's our job to help him. Obviously, he's not a big fan of a dentist. He doesn't go to dentists much. He's afraid of a dentist. So how do we wow him? How do we get this case finished efficiently and quickly and well? So obviously, we're not going to give him a removable prosthesis. We're going for fixed. Looks like he does need a sinus lift. We've got about 6 millimeters of bone. let's see if we could do a little internal sinus lift and put a 10 millimeter implant. That's what we do here. And on the other side, he didn't really need much of a sinus lift. So this case is finished. So this is one visit, put him to sleep. It's a 3.5 hour. You have to move quick. I never work less than with 2 assistants, because to do this in an efficient manner, to get this done in 3.5 hours, you need at least 2 assistants. We place implants, sinus lift, prep, any root canals that are necessary. We press, temporize, and the patient is wide awake and ready to go home with a beautiful temporary, much better than what he walked in with. And after this, the case is basically a slam dunk. You just try the framework, and then you finish the case. That's the case. Less than 6 weeks later, he's finished. Let me ask you guys a question. Do we need to flap for every implant? Who thinks we should flap for every implant? Who thinks we shouldn't flap for every implant? God, you guys are sleeping. Let's try again. You gotta participate. Who thinks we need to flap to place an implant? Who thinks we don't need to flap to place an implant? Okay, thank you. You do not need to flap. You do not need to flap to place every implant. In fact, I try to avoid it as much as possible. Probably 90% of my implant surgeries are flapless. You still need the skills to be able to flap. If there's any question about what's going on, I will flap and take a look. But you want to finish the case least invasively, you want to restore it quickly, you want to have the best gingival outcome with no bone loss, don't break the blood supply, don't interrupt the periosteum, do the surgery much quicker if you do it flaplessly. And you can take the mold the same day and send it out to the lab. So there's no need to flap. And with careful bone sounding, and this is what we do, take your time doing this. This is actually, to me, this is more valuable than a CT scan. There's a lot of buzz about getting a CT scan. I'd rather do this. And of course, you do need CT scan in some cases, but with very careful measurements, you know exactly the anatomy of the bone, and you can place the implant exactly where you want to. So we placed some implants on the bottom, and he's finished. 6 weeks for upper arch, 6 weeks for lower arch, and the guy's a walking commercial. Did we wow him? I think we did. Is everybody going to be asking him, hey, what happened? What'd you do? You look so much younger, so much better. Well, he's going to refer friends to our office. That's internal marketing. It's the least expensive and the best way. Anybody could market externally. And those patients will come in, but will you keep them? And will you get them to refer their friends? So there it is. Can we splint teeth to implants? How many say yes? We can splint teeth to implants. How many say no? Okay, a lot of no's, Let's take a look at the literature. I know it's hard to see, but this is a critical review of literature by Dr. Tino and his team of Cavallero, Greenstein, and Smith. And they took a look at about 30 articles and look back at the success rate of splinting teeth to implants. I know it's hard to see, but most of the studies show, all except one. There's one study by Bragger over 22 patients that has a 68% success rate. Other than that, every single study shows the same success rate. And even Bragger did another study that shows a 95% success rate splinting teeth to implants. The first one's 100%, 95%, 100%, 98.7%, 93%, 95% success rate. And this is over a several year period. So why is the myth out there? That's what I'm wondering. The literature is very clear that if it's a healthy tooth and it's a healthy implant, you should not have an issue. So here's another case, similar situation. Guy has avoided the dentist for a long time, not a big fan of the dentist. So we'll make him forget the experience. We'll give him a little bit of halcyon, give him some oral sedation. Can we do this flaplessly? You betcha. Definitely we'll do this flaplessly. Then the other arch. plenty of bone, do flaccid as well. And there it is. Everything splinted, teeth, implants, all together, cross-arch stabilization. It's not going anywhere. There he is. Couldn't be happier. Last question, I promise. Can we use mini dental implants for permanent restorations? How many say yes? How many say no? Let's look. First of all, you're going to hear all sorts of comments from clinicians. You're going to hear that they're not FDA approved. You're going to hear mini dental implants are temporary implants. Well, let's break some of those myths. We have 510Ks. They are FDA approved. These devices will permit immediate splinting, stability, and long-term fixation for new existing crowns and bridge installation for full partial edentulism, employing minimally invasive surgical intervention. And the other one says, the abutments have been designed to be used in either mandible or maxilla to support removable or fixed prosthetics. So mini dental implants are FDA approved. And don't let anybody tell you that otherwise. Let's look at some studies. What do the studies show? Dr. Shatkin up in Buffalo is probably the most prolific placer of mini dental implants. And his late father and him have been doing this for at least 15 years. And his father was an oral surgeon. He took a look back over 5 years at 2,500 implants that he placed, mini dental implants, and their success rate, 94.2%. Some other studies by Ahn, Mazer, and Bullard, all above 90% success rate with mini dental implants. So the literature is clear of this. It's a viable option. But for whatever reason, it's not being utilized, or not as much. I apologize for the bad picture, but this patient presents to us. He says, he's terrified of a dentist, as you can tell, he's terrified. He says, I don't want any extractions. Don't extract any of my teeth. Can you fix me? I would say, sure. We just need a little more support here, and we can make him a roundhouse bridge. Place 2 small implants just to give you that extra support. We prep and press implant same day. He leaves with a temporary, already looking a lot better than when he came in. This is all one visit. Framework trying 2 weeks later. He's finished. About a month. Again, this is walking advertising. This is marketing. This is how you can build a practice. Impress your patients, wow your patients. Let's take a look at this case. Actually, this is one of my favorite cases. This young lady did not have her 2 front teeth since 1999. Walking around with a flipper. Very embarrassing. She's got about 4.5 millimeter of buccal, lingual bone. So what can we do? What are our options? What's normally taught to flap, try to place a 4 millimeter implant. Obviously, you're going to destroy the buccal bone, so you're going to have to graft, wait 6 months, and then restore. That's what we've been taught. That's what I've been taught. That's what I used to do. Not anymore. It's too aggressive, too invasive. It's just not necessary. When you place mini implants, the implant does the drilling itself. We're removing almost no bone. We're actually compressing the bone, making it more dense and stronger. We're taking bone that may be class 2 or class 3 and turning it into class 1. My drill, which is a 1.8 millimeter drill, only goes up about 8 millimeters, just to create a pathway for the implant. The implant does the rest of the work. The implant, this is a 3 millimeter implant, compresses the bone and does the job by itself. So we place 2 of these. You can see the gingiva has not been disrupted. The architecture remains the same. We could take a mold today and have the crowns ready in just a couple of weeks. This is how she leaves. She was almost crying. She couldn't believe. She couldn't believe it. 12 years with no teeth. And the reason why she couldn't get it done, because it's too expensive. It was too expensive to do it the traditional way. To do almost a year of treatment with the bone grafting and the implants, and the clinician's time, which will take hours, gets to be very expensive. This is affordable. It was affordable for her. And this took maybe 45-minute appointment to do all this. And then a visit after that is 5 minutes to cement it in. We're cutting down clinical time, making the procedures easier for the patients, easier for the doctor, more affordable. Implants are not for the elite anymore. Now people can afford this treatment. And that's the final. And she couldn't be happier. She was almost crying. What can we do here? Here you really have no choice except to do mini implants. Or you can do a bridge. I would not trust these teeth to do a bridge. Obviously she has some perio issues. Even though we'll clean her up, there is a recession. And these teeth are not going to last forever. Place 2.5 millimeter dental implants. Gingiva looks extremely healthy. That's the final result. Now, getting back to one of my first slides about having a good dental lab. I don't take the shade. I cannot do a good job if I take the shade. I have a great laboratory, and the patients will go to my laboratory. That's one of the advantages of being in the city. I have dozens of laboratories in 2-block radius. So I pick the best lab, have the patient go there, have the master lab technician match up the shape. You can't see which one's an implant. And if there is an issue, we're not going to start sending cases back and forth and waiting a week. The patient will go to the lab, get a little custom staining, and they'll still get the crowns the same exact day. And if we looked up and look at the gingiva, that's how it looks like. One more case, we have number 24. That's a baby tooth, and he would like a permanent tooth. The baby tooth comes out, implant goes in same day. You can see how healthy the gingiva looks like. It has not been disrupted. There's not going to be any bone loss at all. We have not interrupted the blood supply. The surgery was not invasive or least invasive. That's the final. And that's the lab technician, that's art. What they did is art. That's perfect. You can never tell that this is an implant. Okay, let's just do a case step by step. So I want to show you how easy it is. And this is done routinely in my office. At least, I would say a couple times a week at least, sometimes more. So this patient would like implant number 13 to replace a missing tooth. We have a temporary ready to go. The temporary is worth every penny. Not only is it patient is going to leave with it, smile with it, but also this is your surgical guide. This will tell me that I'm putting the implant in the right place. It's also going to give me a preview and the patient a preview of what to expect later. So that there's no, well, I want my tooth to look a little bit different. Or my teeth used to look like this. How come this looks like this? If the patient doesn't like it, they'll tell me right away. And on the final, we'll make the adjustments. So we create a surgical guide. We want to place the implant in the cingulum, a little bit towards the working cusp. You got plenty of bone. You can place, I'm placing a 3 millimeter implant. In reality, you can probably place a 4 millimeter implant, and that's fine. But why would we? We look at Tano's rule, the 1.5 millimeter buccal plate, where he did the study, the famous study, and he says on average, if you have less than 1.5 millimeter buccal plate, you will get recession. But that's an average, and we're all different. So why not leave 2 millimeters, so 2.5 millimeters buccal plate? Why not play it safe? So that in 7 years, there's still no recession. The implant's not going to break. the implant's not going anywhere. In fact, it's stronger than conventional implant. This is a one-piece implant. There's no tiny screw holding the two components together. It's a solid one-piece implant. And I like the one-piece implant. It allows me to keep it simple. The more pieces you have, the more components you have, the more complications you can run into, like screw breakage and screw loosening. These I avoid completely by using a one-piece implant. There's my drill, creating a pathway. There's the implant. I have bicortical stabilization. It's touching the cortical bone of the sinus a little bit. It's also touching cortical bone towards the chrome. There's my implant around the cingulum area. There's the implant with a healthy gingiva and plenty of buccal bone around it. There's my surgical guide that's now been relined, and now is my temporary. Patient leaves for the temporary, and here we have the final crown. 2 weeks of treatment, less than 45 minutes chair time. Why not? Similar situation, lower implant. There's the implant. There's the temporary. There's the final. Okay. We also decided to replace that as well. Okay, last case. So, mini implants is just one of the tools. And the more tools you have, the more options you can provide, the more people you could serve. Obviously, we still do conventional implants. I like these implants a lot. They're very aggressive. You've got aggressive threads all the way to the top. And I like to have good initial stability. If I could torque an implant to 80 newtons, I will. And I prefer it that way. She's got a very, very thin bridge. So a 60-year-old lady, she says she doesn't have diabetes, but she's pretty overweight, so I'm wondering, there may be underlying diabetes there. And that's what we did. And let me show you why. That's why. Look at that bridge. Now, we have options here. We could have done the ridge split. We could have put a block graft. And those are all options that I discuss with my patients. And I sit her down and I tell her, Mrs. Smith, we have some options here. We can do bone grafting. We can do a ridge split. We can wait 6 months. Then we can try to put the implants in. We'll wait another 6 months. And then we'll put the crowns on. And this is what I have to charge you. We have another option. I could use thinner implants, and I could get you finished in 6 weeks. And of course the question is, well, are they strong enough? Are they going to last? I tell her, all the studies show over the past 15 years, the success rate is exactly the same. I think I could do a pretty good job for you, and I think you'll be happy. At this point, she trusts me. We had good success with the upper implants. And that's what we do. We carefully navigate the bone with bone sounding, making sure we don't perf. These implants, some of them are 3.0 millimeters, some of them are 2.5 millimeters in diameter, some of them are 12 millimeters long, some of them are 10 millimeters long. I worked with what I had with. We create a custom treatment for the patient. Instead of customizing the bone to fit our implants, why do we have custom implants to fit the patient? Doesn't that make more sense? Instead of just growing bone, trying to grow bone, sometimes doesn't work, very difficult to do in big defects, and then having the failure, having to redo the bone grafts. It's an endless process. People go through for years and still end up with a denture. I like what Dr. Linko had to say. He's one of the pioneers of dental implants. And if you're doing dental implants, you really should know, study up the history a little bit. Look at guys like Norman Cranen, Lenny Linko, and others. David Bezos up in Canada. See what they did, and there is something to learn. Not everything has to be the same 4 or 5 millimeter screw. And Dr. Linko said, to continually true implant for bone augmentation, to create an arena for placement for root form implants rather than place a properly designed implant to fit the unusual or abnormal bone situation is way out of line. And of course, he's talking about subperiosteal and blade implants. But again, this is not that different from a blade implant. The philosophy is the same. They're using a thin implant to compensate where you have very little bone. Okay, so that's the framework. We just tried it in last week. If it's fine, the case is not finished yet. They're putting porcelain on it as we speak. So I think we covered 3 very important topics that a lot of dentists out there don't do. 1, flapless surgery, least invasive surgery whenever possible. 2, you could use mini dental implants. And 3, there's nothing wrong with splinting teeth to implants. And literature shows all of these to be true. So if you don't believe in this, or somebody tells you it's not true, have them show you the literature. And it's time to take that. Thank you for your time. Thank you for listening. And thank you for having me here. I appreciate it.
Dr. Mann, any questions?
Thank you. Yeah, I have one. I'm one of those people that always say don't split teeth with the implant. And I think where that came from was the mere fact that in the earlier days we were screw retained implants, the restorations, as well as we were using external packs. Now that we have internal packs, it gives us a little bit more stability and security of the actual fixation of the restorations. And also, I have cases back way back when, where we were told to connect to that teeth. The best situations where the middle was we were breaking up the span. It was what was in the middle of the span. Those were always.
Actually, one of the main reasons for not splinting natural teeth to implants is because there's no periodontal membrane. And teeth move while dental implants are like in cement. They do not. So there is, I don't agree with Peter 100% that splinting is always the right thing to do. There's probably a place for it and a place not to do it. Sure.
I give you a lot of credit for these very complex cases, but I have to, are you doing your sedation yourself? Are you someone who's sedating? Because you seem like you're doing so much that, for me, I'm a little anxious about it. That's all.
She does that a lot.
It's true. A lot of dentists don't do this type of treatment, and a lot of these things. In my office, it's routine. This is weekly. I do oral sedation. It's not IV sedation. If it was IV sedation, I would need another doctor in the office. I'm trained by docs. I took the docs course, and I'm certified in New York State to do oral sedation. It's a very, very safe technique. We monitor the patient very carefully. And I'll tell you, we really have not had any complications in dozens and dozens of cases.
And what about at all the dents you're doing, you yourself are doing ortho and implants, and do you do the sinus lift, do you do everything?
I don't do everything. Everything you've seen in this presentation, I do.
Wow.
I'm not going to say I do everything, but I do a lot. And if you want to be successful, you should do as much as you can. If you're an orthodontist, you better know how to do Invisalign, braces, everything that's out there, because patients are coming in, and that's what they want. If you're an oral surgeon, the more services you could offer, implants, sedation, extractions, the more you do, the faster you build up your practice. And of course, you have to be competent. If you're not competent, then your practice is not going to be successful.
That he could do because he was a resident of Kings County Hospital. One of the few places in the world that you can learn every modality there is in dentistry. Any other questions? If not, let's give Dr. Mann a